Hey everybody, it's Matt from the NAEMSE office. It's a little bit after 12 here, so we'll jump right into it. First off, I just want to thank everybody for attending this webinar. We're happy to have you here, and we'll jump right into it. This month's webinar is going to be presented by Jenni Salomon. Jenni?
Hi, Matt. Thank you so much for introducing me, and thank you to everyone who's attending. I'm so excited to be able to talk to you folks about this topic. It's timely, it's in the news, and it's something that some people might be a little bit curious about, but not super open to asking about in their agencies or wherever they're working. So, assuring you that I no longer provide direct patient contact care, so I can give these speeches without being called into a supervisor's office to pee in a cup. Please let me be your tour guide through whatever you need to know about cannabis as a first responder. There will be questions assigned throughout, so if you have any questions, ask them. I'm going to get through a bunch of information. I am from the Northeast originally, so if I speak too fast, let me know, and I'll try to slow it down for all of you. The very first thing I want to point out is I like the word cannabis. We speak about changing narratives through our verbiage. I will use the word cannabis intermittently with marijuana. I will describe a little bit of the difference, so don't worry about that. But I wanted to point that out because I think that cannabis is a better word than any of these slang street words that we use. We all like to use the word defibrillate instead of shock so that we look more professional. So we can do the same thing here. So we'll talk about medical marijuana patients, recreational users, and first responders. Does that mean first responders as either of the two, or just how we respond to both? And the answer to that is both. We will do all of that. We'll talk about all of these things. And I wanted to thank a few people and organizations, and this is important to me because I am a cannabis activist. The government of the District of Columbia has been very forthcoming with their documentation about their medical and recreational programs. The New Jersey State Assembly, who I had the great fortune to testify to last year, who has currently stalled in their talks for full recreational use, but they've been a really big source of information for me. The Marijuana Policy Project, NORML, the activist and grower DC Scrogger, and some original activists, Mary Jane Rathbun and Dennis Perrone. I need to mention those people as well. Through all of these people and these organizations, what we're getting now is we're having normalization and education. This was a cover of the New York Daily News back in May. So it's not even a whole year old. And this is the cover of a mainstream publication. This is not just High Times on the back shelf at Barnes & Noble. So we're speaking about it. We're seeing a lot more about it. Famous people are out there. If you've seen Snoop Dogg or Rihanna or any of these famous folks who advocate for it, you'll see that it's becoming more normal. Why is this the case? Because we're finding that there's a lot of indications for medical marijuana. Cancer patients, HIV patients, MS patients, some seizure patients, and other spasticity disorders can all benefit from medical marijuana. Intractable pain, so that's chronic pain that is not responding to other things. Glaucoma, Crohn's disease, hepatitis C, and diseases that result in these nausea, vomiting, and wasting situations. Also very effective in PTSD patients, which might be something that you find yourself encountering more often. Traumatic brain injuries and chronic renal failure patients also can all benefit from medical marijuana. So when we compare it to things like OxyContin or Percocet, these opiate pain analgesics, we see that it's actually a relatively safe medication. The reason it's safer than those is because it does not result in overdose death. That's not to say that there are no overdose or overconsumption situations. It just doesn't result in death, that's a win in my book, honestly, at the end of the day. I don't know about you guys. But it's not as addictive as things like cigarettes or alcohol. There are some studies, and I'll mention my issue with studies in a little bit, There are some studies that say that some recreational users may develop a dependency on it. There's not a lot of info on dependency in medicinal users, and there are a number of reasons for this that have to do with research and the challenges cannabis has in the research realm. People with a personal or family history of psychiatric disorders who use cannabis are at higher risk to develop or aggravate an already present psychiatric disorder. So basically, anything that's going on, cannabis can amplify. That's why, as a medication, patients will have to work with a physician, a cannabis physician, who will be able to monitor their use, just like any other medication that this patient might take. It can be dangerous for people with cardiopulmonary disease, respiratory insufficiency, or liver or kidney disease. Again, however, when used in a medicinal fashion, supervised by a physician, maybe an MD or a DO, or even a naturopathic doctor, I think in the state of Washington, there's 6 different practitioners who can recommend medicinal marijuana. Those people should be involved in the care of the patient. So there are some side effects. We see that there are side effects to a lot of medications. You watch the commercial on TV of the person hopping through the field of daisies, and it's a commercial for urinary incontinence. And there's a list of 75 different side effects, and they might include, seizures and death. So all of these medications have possible side effects. The ones of cannabis or medical marijuana, we can talk about headaches and dizziness. People might feel drowsy, which might be their intention in the first place of consuming it. Things that they probably don't like are dry mouth. The nausea, we should go back. I fast forwarded that. Okay, so dry mouth, nausea, paranoid thinking, all of these things are possible side effects. It also might increase appetite, which is not necessarily a negative side effect. Remember, we spoke about patients who needed to take this for nausea, and they needed to be able to increase their appetite. It can cause an increase in the heart rate. That's something that's interesting to note. That's something that we can touch on in a little bit. I want to talk about how we would use this information if you're an educator, seeing as this is hosted by NAEMSE. It can increase or decrease blood pressure, and it can also impair functioning. So hopefully you're not encountering these patients after a motor vehicle accident. Hopefully you're just encountering them in the course of something else. Some reports have suggested that you might increase your chance of acute coronary syndrome, heart attacks, and or all of this atherosclerosis and risk factors that can lead to heart disease. Again, I really want to mention that I want to talk to you about the challenges involved with researching cannabis and how you need to be careful with whatever research you do encounter, because there are people out there who have a vested interest in not pursuing cannabis research or cannabis legalization. I'm sure you can think about it. I'm not telling you to be a conspiracy theorist, but there are physicians who mention that it's easier to recommend one plant than write a prescription for 6 different medications. So studies can be skewed. You're well aware of that if you've seen anything. So just double check everything that you see. I wanted to include it because I wanted to be inclusive, and I don't want to not tell you that there's been some information that says this, but I'm going to get into what goes on with the research shortly. It's also important to note, in many of these cases, people who experienced these events after smoking marijuana already had other risk factors going on. So it's possible that they were cigarette smokers, which is still bad. Like, nobody should be smoking cigarettes. That's a whole nother presentation. Or being overweight. So people have comorbid factors. As a matter of fact, there was a horrible, horrible case study presented regarding a younger person who had tested positive for cannabis in their system and had sudden cardiac arrest. that was shocking when you looked at the headline that way. What they also failed to mention is that this patient also had some toxicology come back for a ton of alcohol, cocaine, and ecstasy. But the article headline was like, oh, this person had cannabis in their system and they had sudden cardiac arrest. Well, yes, they had cannabis in their system, but it probably was one of the other things that is known to cause sudden cardiac death. So I keep mentioning the issues with research. Right before I talk about methods of administration, I keep bringing it up, so I think it's important to talk about. With medications that go through clinical trials, they're often sponsored by medication industries. Big pharma can sponsor this because of the legalities of cannabis. Any clinical trials, they get a smaller budget and they have to apply through the National Institute of Health. Once they get approved, the cannabis is provided by the government for them in cigarette form. So it comes from one source. It's delivered in a suboptimal way. So the research is not able to really do honor to all the things that the plant can do. That being said, of these methods of administration, only one of them is the way that these clinical studies can actually happen. And that's smoking it. That's inhalation of cannabis. People use joints, blunts, and pipes. They might use a bong. If you've ever walked into a novelty shop and seen a sign that says, please refer to them as pipes and water pipes, that's because people are afraid of the word bong. But there are these street names that are out there, and that might be what you are familiar with it as. Additionally, people are vaporizing cannabis. This can happen in a number of different ways. They can vaporize the dry herb. They can use a lot of different accessories that are out there on the market. There are devices known as vape pens, and they've not been tested, and there's no quality control. So you might find people using black market vape pens that are not coming from a medicinal dispensary. And these people might present with certain respiratory issues because there's no quality control. So just like buying something else that you would inhale from a random person down the street that has no testing or quality control, you should be a little bit concerned with what you're breathing into your lungs, or what your patients should be breathing into their lungs. It can also be eaten or drank. Foods can be infused. These are your brownies and space cakes, teas and candies, and pretty much anything. Honestly, if you search Instagram, you will see any and all sorts of food that has been infused with cannabis. So it's out there, which kind of makes it a more interesting question when you're asking your folks their assessment questions and you want to know about the last thing they ate. If they mention that they ate their roommate's brownie out of a fridge 2 hours ago and now they have the worst dry mouth in the world, maybe accidental cannabis intoxication should wind up on your list of differential diagnoses. Extractions and tinctures are concentrates. They can be eaten, smoked, or applied topically. As far as topical use, I will tell you personally, I have a family member who suffers from rheumatoid arthritis. I have persuaded this family member to give it a shot with the topical patches, and this way they don't become intoxicated with cannabis, but they're actually finding relief from topical use. So you treat these just like you'd treat any other medication patch. You would take it off and wipe it off. And just be aware that it's out there. So there's a bunch of different ways that people are utilizing cannabis. However, with THC content higher than 0.3%, cannabis is still illegal under federal law here in the United States. Now, I had to put this with THC content higher than 0.3% in here because remember I mentioned that sometimes the terms can be confusing. Cannabis describes a plant that has a number of qualities, and when that plant has a THC content less than 0.3%, chances are that's the hemp version of the cannabis plant. The hemp version of the cannabis plant is now legal under the Farm Act that was just signed December 20th. Current political climate might change how things are happening, and I'll touch on that in a little bit too. But what we're talking about for medicinal purposes is usually the marijuana version of the cannabis plant, which has a higher THC content. Now, I'm throwing out words like THC. I'm telling you that cannabis can refer to both hemp and marijuana. Hemp is what we should be making rope from, and clothes and textiles, and hempcrete if you are a green builder. I personally don't think that we should be making medication out of hemp currently. This would be because a lot of the hemp sources that we are finding are grown not here in the States. And again, we come back to that whole, it's not tested, and we can't verify, our analysis of its biochemistry. So that being said, everything I'm speaking about here, I still need to make the disclosure that even under a qualified medicinal program or a full legal recreational state, we are still dealing with a plant that is illegal under federal law. Now, a little bit of background as to what's going on with that is that in 1970, the Controlled Substances Act was signed into law, scheduling cannabis as a Schedule I drug. Schedule I means it has a high potential for abuse and no approved medical use. Because of the being of the same family, hemp was also made illegal. Like I said, that's recently, very, very recently changed with the Farm Act bill that was signed. But for 48 years, cannabis has been completely illegal. In 1996, Proposition 215, it was the California Compassionate Use Act. It was the historic law that made it legal in the state of California to both grow and possess marijuana for medicinal purposes. Our original activist that I mentioned back in the beginning when I thanked him, Dennis Perrone, he's the one who worked on this California Compassionate Use Act, and he's the one who said all use is medical. So it also started that push for full legalization. That might be a very personal thought for you if you think that all use is medical or not. But as practitioners, we're not necessarily judging. We're just getting all the information about what's out there so we can better treat our patients. But you will encounter people who do believe that all use is medical. Personally, I can see the validity to it. I also tell people that food is fuel. So I think that there's a lot of things that we could use that are medical in our lives without being prescribed by a doctor. Nowadays, we have full legal recreational marijuana in 10 states plus the District of Columbia. And you've got legalized medical marijuana in some shape or form in a number of others. So more than half the states, we have some form of legal marijuana. You can see the West Coast is the best coast when it comes to that, I guess. And you'll find traditional values in these center states are kind of causing a delay. In New Jersey, we were really hopeful that we would have full legalization. Unfortunately, those talks have stalled. We've been told it's in efforts to get it right. There's a lot of people who are impatient, but it's happening. Illinois just came on board recently to expand their medical program, and Michigan, I think, is the most recent state to approve fully legal recreational. Again, it's still federally illegal, but in those states, it is legal. This is a confusing subject. There's a lot of ways we can talk about it, but we don't need to because it's more important to talk about why it's so timely, what we're finding out. And we're seeing that the cannabis industry is getting huge. 1996, we have our first state legalize medicinal cannabis. Up till a few years ago, we still had states struggling with medicinal programs. However, because we are able to see more studies, because there's a lot more access and education, these advancements are going to be happening exponentially. So depending on where you are, you might in a very short time go from complete prohibition of cannabis to full legal recreational use, which will mean that as providers, you will see more and more of your patients using this. You'll see your own family members participating, and you'll wonder if you can as well. I will mention that as well a little bit later. But I want to talk about more why it's timely, why cannabis is becoming such a big deal. JCO, those people who were awesome and fantastic and made us all very, very aware of if we had gloves on when rolling our patients into the ER. One of their other endeavors in the early part of this century had also been to increase patient satisfaction. And they really promoted the idea that patients don't need to be in pain. And as a physician, you should be doing something to mitigate the pain that your patients might feel. That combined with a robust industry, physicians were giving out more and more opiate analgesics. They were treating their patients with this. So we've got a lot of patients who are encountering pain. They see their primary care physician, and the standard of care, the standard best practices is going to wind up being long-term opiate use. And this was great. Patients weren't in pain. Everybody was happy, except 60% of unintentional opiate overdoses occurred to patients who had prescriptions from a single provider. Many of them were for low doses. So this opiate epidemic that's happening in our country, we can look around and say, oh, it's this cheap black market heroin that's flooding our streets from foreign places. And well, I'm sure that might be part of it, but more than could even happen with that. 60%, more than half of these unintentional opiate overdoses are happening to patients who have obtained these opiates in a legal way. These are not people who have met with a shady drug dealer in a back alley buying some sweet, as to paraphrase from Cards from Humanity, black tar Mexican heroin. These are people who are getting a Percocet prescription for their rotator cuff injury. And for one reason or another, unintentional opiate overdoses happen. When I testified to the New Jersey State Assembly, that was one of the things that I made sure to mention, that in my career as a paramedic, no one ever called 911 for cannabis. Not a single person. I know that it's happened, but in my career, no one called. I did, however, give out Narcan like it was going out of style. And I've seen it become more accessible for police officers and other first responders to be able to give it as well. And there's something to be said for that. So people are looking for an exit drug, potentially. People are looking for other viable options. And the reason this works, the reason cannabis can work, is a little bit about the endocannabinoid system. We know less about this because we discovered the opioid system before, but now we know a little bit about the endocannabinoid system. And I don't want to get too in depth, but a little bit of the anatomy and physiology of it. There are three things that comprise the endocannabinoid system. We have cannabinoid receptors, and these are receptors that are happening in your body. There are two main ones that have been researched. It's possible that there are others, but I mentioned the issue with research and the challenges. We might get this information down the road, but right now it's a little bit limited. So right now we're dealing with these two main researched receptors, and these are scattered throughout the central nervous system, the brain and the spinal cord, and some of the peripheral organs to benefit the immune system. Receptors are not concentrated in the cardiorespiratory area of the brain. So opiate receptors, when they are set off, quote unquote, by opiates, they will help depress the respiratory drive. Cannabinoid receptors, when they have endocannabinoids in them, do not depress the respiratory system. So that's a huge, huge benefit. This is why cannabis is a viable alternative in some practitioners' minds, in some patients' minds. This is why there is a push in medical states for physicians to start looking at cannabis as a viable option for pain management. In addition to the receptors, you have the endocannabinoids. There are two known that happen in your body. So your body produces these endocannabinoids. They are produced on demand as an adaptive response to cellular stress. And there's a really special way about how they move. That's a whole nother half-hour conversation. But what they actually get to do is they get to provide feedback for other neurotransmitters. So you have endocannabinoids that are happening inside the body. Your body naturally produces these. If I were to reference an exocannabinoid, that would be a cannabinoid that is coming from outside of the body. So the cannabis that people are smoking or drinking in tea or eating in a brownie or vaping in a dab bar, those are exocannabinoids. So all of these cannabinoids fit into cannabinoid receptors. There's also enzymes. You just get to know that that's an extra part of it. We don't have the extra 45 minutes, but we could talk about the anatomy and physiology of this for forever. When we talk about those exocannabinoids, these exogenous cannabinoids that are coming from outside of the body, the two main chemicals that have been researched before, and remember I said THC and CBD, I'd touch on it. This is where I'm doing that. THC has this big, long, special name with a Greek character in it and a number. So it's, it's going to have some interesting side effects. We call that delta-9 tetrahydrocannabinol, and for short, THC. So the things about this is that it's psychoactive. It is an analgesic. It is an antispasmodic, a muscle relaxant, an anti-inflammatory with 20 times the efficacy as aspirin, and an appetite stimulant and antiemetic. So not only will it stimulate the appetite of a patient who needs it, it will also help prevent them from vomiting. Fun little fact you can use down the road when we talk about cannabis interacting with other medications. Keep that in mind about the antiemetic properties of it. On the other hand, you have cannabidiol. Cannabidiol is the other part. That's what we call the CBD. It is a non-euphoriant, so it doesn't have the psychoactive properties as THC. This is the neuroprotective chemical that's in cannabis. This is what the Harvard studies are saying. Hey, this might be really great for your Parkinson's patients to slow the progression of the disease. It has immunomodulatory properties, anti-inflammatory properties, analgesic, and anticonvulsant. Anticonvulsant is really important when we talk about what some of these are used for as well. And that CBD fits into not just the cannabinoid receptors, but also opioid receptors, dopamine and serotonin receptors. So because the CBD fits into these multiple receptors, this is where we see a little bit of why people might want to use cannabis instead of opiates, why they might want to use CBD or CBD-rich cannabis to treat a number of different things. Anxiety and depression can all potentially be helped by this. The whole plant has superior therapeutic benefits, and this is definitely something to talk about because there are medications that come from it. People see the CBD gummies at the gas station, possibly. This is where I have my own personal thoughts right here. If you see this bottle of CBD gummies right over here, this is advertised on the internet. If you live in a state where CBD is legal, you can go ahead and buy these 10 milligram gummies. Except 300 milligrams of CBD is the minimum amount that we are advising for efficacy. Chemical constituents require biochemical analysis. This biochemical analysis is very hard to do in the absence of legality. So if you are into research, if you are into finding out what these things are, I encourage you to go ahead and advocate for the legality so that way these things can be tested and people can find out. Because if CBD is going to help you with a number of things without making you feel the psychoactive effects, then, I think it should be available to everybody, but it should be safe and tested. There are 2 FDA-approved THC medications. These medications have been around for a while. You've got Marinol and another one that's used for cancer patients. And these have been around for a while. They've been used, they've taken out the parts of it that work. So the Marinol was developed in 1985, and it's a semi-synthetic cannabinoid. And it was prescribed for cancer patients with nausea and vomiting and AIDS patients as an appetite stimulant. There's another one known as Sesamet that came out in 2006, and it's a full synthetic THC, and it's given to patients with cancer as an antiemetic, and off-label it's also given to fibromyalgia patients. There were a few issues with isolating this THC in this medication, and some of those would be the fact that their use is limited. The cost is up there because it's coming from a medication, a pharmaceutical company. So there's a cost factor to it. Additionally, patients had a high dropout rate because the side effects, they were just trying to treat the nausea, the vomiting, the appetite. They weren't trying to decrease their function, which is what you get sometimes when you experience the psychoactive effects of THC, the quote unquote high. We also found, especially with Marinol, they were getting a dosage that is a little bit too high. For reference, they were getting a study dosage of 15 to 16 milligrams. In California, if you go eat recreational chocolate, they recommend that you start with a dose of 10 milligrams. So we have these challenges associated with studies. We have a high dropout of this isolated THC-based medication. We're finding that the whole plant is preferable. There is currently no synthetic CBD medication out there. There is one in studies. Epidiolex is being studied to give to Dravet and Lennox-Gastaut syndromes, which are seizure syndromes in children. These are your high-profile court cases of parents of seizure children going to court saying, cannabis helps my child have less than 300 seizures a day. These are those two syndromes. So they are really benefiting from the CBD, but there is currently no approved synthetic CBD out there. Sativex is in phase 3 trials. It is a whole plant extract, but it's not currently approved for use in the United States. It is marketed overseas, so if you are someone living in Europe, you might encounter this. But right here, we're still in trials for it. That is a medication being given for MS symptoms and neuropathic pain, and also cancer patients who have pain refractory to opioids. However, the doctors are still recommending the whole plant. It helps avoid these side effects and cost challenges of these THC-based medications. The one thing that there are issues with for these physicians, if you ask them, is that they're citing concerns about a lack of control over the product, which is very understandable because it's a plant. How are you going to control it? There's issues with quality, especially depending on who's growing it. If your buddy is growing it in his basement and there's a ton of mold on it, that's not going to be as healthy for you as something that's been regulated and grown by a grower or a licensed grower. Some of them are labeled, some of them are not. It's hard to determine chemical constituents just by the strain or name. They do require biochemical analysis, and I don't know anyone with a lab set up to analyze their personal use cannabis in their basement. Additionally, there's an entourage effect, which is another reason people want the whole plant. The entourage effect talks about the fact that there are hundreds of additional therapeutic compounds in the whole plant above and beyond just the THC and the CBD. You may hear people talk about terpenes and things of that sort. That's what we're talking about here, is that there's a powerful synergism with extracts from the whole plant. And this was shown in a study with mice that if they got the whole plant, the effects were 330% greater than isolated THC. So there's a lot of benefits to the whole plant here, and that's why this is timely. That's what people need to know about, and for the further legalization of medical and recreational cannabis. remember I said before that anything that you're doing, cannabis can kind of potentiate? This is why medical cannabis should be monitored by the recommending physician. Most physicians can't prescribe it, they're recommending it. And so things that you might want to know as a first responder who's responding to a patient who lists cannabis as one of their medications. Coumadin, warfarin, because of what happens and taking it together in combination with marijuana, the effects of the Coumadin might be heightened. People might experience longer INRs. Same thing with Prozac. And then a lot of medications that are changed and broken down in the liver. Sometimes using marijuana concurrently with these medications will lengthen the amount of time it takes for these medications to metabolize in the liver. Some of those medications are, Tylenol. So Tylenol might be something that someone might be taking for pain. They might also be taking cannabis for pain. This would be something for their physician to monitor, because if the cannabis is going to cause the Tylenol to take a longer time to be broken down, you'd want to ensure that the patient is taking Tylenol so that they avoid Tylenol toxicity, because the Tylenol is going to be more dangerous than the cannabis, but the cannabis might make it so that it takes longer for the body to metabolize the Tylenol. If you're following my train of thought there, what that means to me is that the marijuana might make the Tylenol more efficient, and you'd have to take the Tylenol only once a day instead of 3 times a day. But this is something that should be monitored by the physician. Some other medications moved by pumps into cells, and marijuana might slow these pumps down and slow down the absorption of these medications. Things that you might recognize on this thing right here is this cardizem, this diltiazem right here. We are aware that this is a medication that a lot of our ALS providers are giving to patients. They're giving it in an emergency situation. So we'd probably be more aware of interactions in a long-term situation, but it's still something to keep in the back of our mind. And we can use this if we are educators, because this is a NAEMSE program. We can use these little bits of information in case studies, and that might be how you bring these little tidbits of information to the awareness of your students. Corticosteroids, Allegra, a couple of other medications that you might recognize have made it over here as well. Just take a look, and there's a lot of information out there. I'm happy to send you a copy of this later if you want the whole list of medications. So if you were to respond to a patient's house and see any of the above things, you might decide as part of your patient interview to ask your patient if they are a medicinal or recreational marijuana user. You don't need to specify. You can just ask your patient if they are a cannabis user. And if we start that conversation, we might help normalize it for these patients as well, because there are courses out there. The University of Washington has a whole course for healthcare providers, and they're advising these folks how to bring it up to patients, because patients might not know that this is a viable option. There was a court case out there as well that spoke to healthcare providers' rights and practices and protections. And we're talking about the fact that it's not illegal to advise a patient about the risks and benefits of the medical use of cannabis. Like I said, out in Washington, D.C., Washington State, you have MDs, PAs, DOs, OPAs, NDs, and ARNPs are all able to recommend cannabis. So there's a push to educate healthcare providers on how to talk to patients about it, because a lot of your patients are really, really benefiting from it. Medical patients usually have to present with a qualifying condition. They have to have that condition documented, and they need to make a cannabis physician aware of whatever current medications. That cannabis physician will usually be able to present cannabis as one option among many, and it will encourage more openness, because if we can encourage more openness, we will normalize it, and people might not be as afraid to seek this out to treat their illnesses. So the challenges that we face as providers are mostly or easily overcome. A lot of them are just psychological, and it's about changing the perception. So you sitting here today listening to this webinar is exhibit A of that, because you're out here finding out what's being presented from a professional organization, and it might change your perception. It might help you change the perception of your patient, because at the end of the day, the science is overwhelmingly positive. There is conclusive evidence of efficacy in pain management for medicinal cannabis. And it's decreasing their pain and it's increasing their function. And providers aren't comfortable because they don't have all of the information. And there are still those discrepancies between state and federal laws. But there's so much out there that's good about this. I spoke about how you might use some of this information in your education, in your case studies. And how does this affect you personally? Can you go home and smoke a bowl with your partner after work? And sadly, you probably cannot, because cannabis is still federally illegal. Your agency has to comply with the Drug-Free Workplace Act, which is a little bit crazy because I keep mentioning cannabis as a medication, not as a drug. Until it's rescheduled and taken out of that Schedule 1, you could jeopardize your whole agency. If something happened and you tested positive for cannabis, you could jeopardize your whole agency. And what makes it almost not fair is that you might see your coworkers go use alcohol very liberally, if not too much. And as long as they don't have any more alcohol in them by the time they go to work, it's fine. This person might have a horrible, horrible, alcohol dependence that nobody can say anything about. And they spend their whole shift just shaking, wait until they can go home, get and have another beer. But because cannabis stays in the body for in excess of a month in a heavy user, you might not be actively intoxicated by cannabis, but your body will still show it being in there. So until federal law is changed, things like that, and workers' compensation, line of duty death benefits, and life insurance, these are all challenges you would face if you're looking at just you and not even your whole agency. So I implore you to actually, if you care about this, go ahead and get active. Go ahead and testify to state assemblies, or get involved with activists. Find out how you can help, because at the end of the day, I mean, we speak about PTSD in providers and how cannabis is good for PTSD. It seems a little counterintuitive, and I know there are people out there who have a mindset that cannabis is still a drug. And we're not going to be able to convince those people. If you're one of them listening to this lecture, I wasn't able to convince you that it's not a drug. Hopefully, I encourage you to know that there are patients out there who are using it in a medicinal fashion, and you'll be able to treat them a little bit better. But things change slowly. People's minds change slowly. If you are in the fire service, another interesting thing to note is that under U.S. law, dispensaries are not eligible to receive federal disaster aid disbursements. This means California, our state with a ton, like so many wildfires, they might have an issue if a dispensary, which is legal by state law, were to suffer from that forest fire. They might not be eligible for federal disaster aid. So these are the challenges presented to folks in even the state legal cannabis industry. These are things that will hopefully change. I'd love to be able to do a follow-up in a year and tell you about everything that's changed. But these things happen slowly. And I didn't even get to make it into a full-on slide, but I wanted to get the information in here just so that you guys know. I mentioned the Farm Act legalized CBD December 20th. It was done according to MMJ.
Hey, Jenni.
Yes.
Sorry to interrupt. You have a Dell update pop up on the bottom right hand.
Is it gone?
Right, perfect.
How long has that been up there?
Just for a few slides.
All right, cool. Well, if anyone missed any information, I'm happy to go back and go over it. I will install this update later. Sorry, I promise all of you IT people. So talking about this legalization of hemp and how this might affect CBD and what's going on with this. As part of legalizing hemp, there are a number of things that need to happen, and the U.S. Food and Drug Administration needs to be able to do things for this legalization to stick it out. And there are studies that they're supposed to do, and there is people need to submit for an oversight plan. Unfortunately, because we have our government shutdown right now, this might impact this down the road. Other agricultural, economic, and statistical reports and projections are not continued under the federal shutdown. So we'll have to see what happens. The USDA has 1 year to study the 42 hemp states' progress with the plant. I wonder if they will push that out or if the studies will just be of less than 1 year. But I thought this was very timely, and I wanted to show you how in the mix all of this is right now, and where we're at and how everything around us it's kind of all connected. You guys have been in here. I've kind of gone over a lot of information. What I want you to take from it is the THC and the CBD and what benefits your patients might be getting from them, a little bit about the endocannabinoid system, and then just a few more extra things. I think I've given you guys a lot of information. I haven't seen any questions pop up, but if there are any, ooh, there we go. Oh, that was one of them. Yeah.
Yeah, just a few questions there, Jenny.
Yeah, it's a littler box than I thought I was looking for. All right. Thank you for your grace and understanding that. So let's see. Update. Can we get these slides? Currently cannot see all of the slides due to the notice of the Dell update. Okay, got that one. We took care of that. Absolutely. Do I see cannabis as a gateway drug? And if so, what is my response to those who argue that cannabis is used as such? Well, we already spoke about the fact that people who might have a propensity for psychological disorders, including substance abuse, could find that those things are made worse by cannabis. To those people, they should be avoiding not just cannabis, but anything else that they might see as a gateway drug, including nicotine or alcohol. So I think there's validity to that. For the vast majority of the population, however, no. Personally, I do not believe cannabis is a gateway drug. I think alcohol is far worse than cannabis. I think cannabis is a plant and it's a natural substance. There's a lot of health benefits to it. I personally have a very, I have a community around me that's very concerned with health and things that are healthy. A lot of my friends are vegan and organic. So I see them speaking about food as medicine and benefiting from other plants in other ways. I think that it's easier to see cannabis as just another herbal supplement if you subscribe to that way of thinking. I think for people who are meat and potatoes folks who like a steak and a baked potato just because that's what they like and not necessarily for its nutritional value, the folks who sit on a couch who are not as concerned about their health, but they want to be law-abiding citizens, they might find themselves viewing it as a gateway drug because it's just different from what they're used to. So that was a really good question there. Again, you're not going to be able to convince everyone that it's not. And those are the people that you just have to hopefully not get into an argument about. This is very helpful here in Oregon. Oregon, you guys actually, you guys decriminalized cannabis way before California even had the Compassionate Use Act. So I'm glad that this is helpful, but I feel like you guys are, like the OG place for information on cannabis. Okay, so now that I can see these questions. Are there any others that anyone might have? I'd love to answer them for you. I know that this presentation will be available through NAEMSE, so you'll be able to have all of this information. I am happy to send out these slides to you. I'm happy to chat with you about anyone else and normalizing cannabis. I am so grateful. Oh, here we go. Gateway drug. Since cannabis is legal in Oregon, they are proposing now adding magic mushrooms as a legal medicine. Yes, that is a very, very interesting thing. Psilocybin and LSD are also qualified as Schedule I drugs federally, so they are also federally illegal. Personally, I think a lot of these psychotropic drugs have potential merit, but you need studies to figure out, you need science, you need evidence, and not just anecdotes of the fact that my mom uses a patch of topical cannabis for her arthritis. You need real studies, and we have these challenges with the studies because of the legality. So whether you think it's a good idea or not, to have these things rescheduled is the first step in being able to have the research about them. I read the Forbes article, just like a whole bunch of other people, about Silicon Valley CEOs microdosing with LSD to increase their creativity without worrying about the psychotropic effects. And it was a really well done piece, and it made me curious to know more. It's hard to know more when the research is so hard to do. So definitely advocate for those things. Thank you for the interesting question about that. Are they allowing real cannabis in the studies, or is it still the government brand? The government brand is real cannabis. It comes out of Mississippi, but that is currently the only cannabis. However, because Canada just legalized cannabis as the first G7 nation to do so, we're going to see a lot more studies come out of Canada. There's a really good study that came out of the European Union, and we're going to have to rely on foreign studies for a lot of this for ourselves to figure out what's going to work, because we're just not going to be able to. But yeah, that's the government branch, the Mississippi outdoor stuff. I'm kidding, it's not outdoors. They probably cultivate it in a basement somewhere. Okay, so that's that. Everybody's still here, which is really cool. Matthew, were there any questions that might have been sent in by anybody else that weren't able to stay, or anything else I should talk about?
It looks like that's it for right now. I'm going to share your email address in the chat box. So if anyone has any more questions they'd like answered, feel free to reach out to Jenni. Also, if you'd like the slides, reach out to Jenni. And I think that's it. Awesome. So with that being said, I don't see any new questions coming in. So I want to thank everybody once again for attending this month's webinar. And Jenni, I want to thank you for presenting this month's webinar. Much appreciated.
Thank you for having me.
Yeah, absolutely. And we will see everybody next month. We don't have a date as of right now for next month's webinar, but we'll get it up as soon as possible. So on that note, we'll end it here. Thank you, everyone, and goodbye.